side. So for everyone who is joining online, we're just getting together here in the main room, and we should be starting in the next couple of minutes. So thanks for joining your time.
So thank you very much for attending this workshop on OFG and Crohn's disease, organised by UCL, Eastman Dentistry Institute and Avena Limited, who worked on biomarkers. First of all, I'd like to thank everybody for coming. Before I start, so we're going to start this presentation in two ways. We're going to start it on the background of Crohn's disease and OFG from a research point of view, and then we'll go on to a clinical perspective, and then finally Avena will talk about their groundbreaking diagnostics capabilities. And at the end, hopefully we'll have time for some questions and answer session. So if you have any questions, please leave them to the end, and then we'll get on to them as soon as possible. Okay. So I'd like to start with just introducing myself. So I'm Professor Andrew Smith. I'm a immunologist and cell biologist who has a strong interest in Crohn's disease and orofacial granulomatosis. And I wanted to kind of discuss, first of all, the kind of overlapping kind of conditions that drive chronic inflammatory disease. So chronic diseases such as inflammatory bowel disease, Parkinson's, asthma, type 2 diabetes and rheumatic diseases are all caused by a combination of environmental factors, genetics and your human microbiome. So the microbiome predominantly is in your oral cavity in your gut, but can also be found in your skin and in your nasal passages and your genitals. But the microbiome is influenced as well by environmental factors. So all these things work together. And in certain individuals, these factors come together and result in an increased risk of developing an inflammatory disease. My lab's, one of the main areas of my lab is the oral gut axis and its relevance to IBD and OFG. And what happens is the GI tract, of course, starts at the mouth and finishes in the rectum. But in between these two sites, these organs are full of bacteria and immune cells, and they are interacting with each other. So cells that reside in the gut, such as in the immune system, can traffic through the bloodstream back to the mouth, influencing the oral cavity. And also the microbes from the mouth, of course, when you swallow them, can travel down the GI tract and influence lower down in the GI tract. These two sites are heavily influenced by diet, lifestyle, genetics, the health of the individual, and also one of the major causes of perturbations in these regions is medication such as antibiotic usage. There are a number of facts that are worth knowing about the oral gut axis. So the oral gut axis is the major reservoir of microbes within the host. The highest concentration of microbes are found in the gut, but an awfully high concentration of bacteria are also found in the oral cavity. You can have up to 100 billion microorganisms in 1 milliliter of fluid from these cells. The stomach acts as a barrier. So because of the acidic conditions that you find in the gut, in the stomach, this stops bacteria translocating from the mouth into the lower GI tract. And this is extremely effective, and it will kill most of the bacteria you swallow, but not all. Some bacteria are able to get into the lower GI tract. And when they get down there, they're able to influence the immune system, and sometimes this drives a pathological condition in some individuals. Also, oral microbes have been associated with inflammatory bowel disease and also colorectal cancer in recent years. So inflammatory bowel disease is an umbrella term. It is used to describe two different conditions, dominantly Crohn's disease and ulcerative colitis. And about 45% of individuals with inflammatory bowel disease will have Crohn's disease, and another 45% will have ulcerative colitis. And then you've got 10% of people with something called indeterminate colitis, and this is a condition where they're unable to prescribe both Crohn's disease or ulcerative colitis. And usually people with indeterminate colitis, as their disease develops, are able to go and put into either Crohn's disease or ulcerative colitis. The two conditions are quite different. So in the case of Crohn's disease, it affects the entire GI tract. It can start in the mouth, and it can also affect the large and small bowel. It's a patchy inflammation, So there's areas of inflammation, and then there's areas of normal tissue, and then you can have another area of inflammation. It is associated with a thickening of the gut wall, and this thickening of the gut wall causes strictures or blockages in the gastrointestinal tract, and these are usually require surgery to be removed. And it's also associated with a defective immune response, and the immune response that's defective is usually against bacteria, and it's this defective immune response that drives the condition. On the other hand, ulcerative colitis only affects the colon. So it's a colon-specific disease. It is a continuous inflammation, and in this case, you don't get thickening of the gut wall, you get loss of the gut lining. This gut lining loss causes a kind of a condition where you have bloody diarrhea, and it's associated with an overactive immune response. Here we're talking about OFG, so Orofacial Granulomatosis, and it's linked with IBD, but it's predominantly linked to Crohn's disease and not ulcerative colitis. So Crohn's disease affects about 0.3% of the UK population, and that accounts for about 200,000 people in the UK. Of these people with ulcerative, most of them will have small bowel involvement, so the terminal ileum will be affected and inflamed. On the other hand, about 50% of these, 30 to 50% of these will also have large bowel involvement, and about 30 to 60% of these people will have oral involvement in some way or other. But these oral manifestations can be just ulcerations, stomatitis, periodontitis, or OFG. So there's a lot of different oral manifestations, and this will be covered by my next speaker, who will tell us a bit more about the manifestations in this condition. So the strong association between OFG and Crohn's disease is driven by pathology mainly, and kind of phenotypic kind of presentation. So what both of them suffer from is ulcerations and fibrotic development within the tissue. So you get lip thickening and you get wall thickening in the colon. You also get granuloma formation. So it's the granuloma formation that's the hallmark of these two conditions. And the granulomas are quite interesting structures in their own right. The granuloma is an aggregation of macrophages. So these are cells of the immune system that are able to phagocytose antigenic material and foreign material such as bacteria. And this occurs, the granuloma forms when the macrophages take up this material, are unable to deal with it sufficiently and clear it by digestion, and they form a granuloma that walls off the inflammatory stimuli from the rest of the tissue. Normally what happens in an individual, if you've got an oral break in the mucosa, bacteria will enter the tissue will then recruit the immune cells will come in and they will take up the bacteria, and if they can't digest it fully, they will form a granuloma. This granuloma then will recruit more immune cells, but over time, this granuloma will usually dissipate and will disappear in a healthy individual. And this is normally what happens in an acute inflammatory response. In a number of individual cases, such as Crohn's disease and orofacial granulomatosis, what happens is this granuloma doesn't disappear, and what happens is this drives a localized tissue inflammatory response. The granuloma starts to break down necrotically. It also releases a large amount of inflammatory molecules, such as TNF-alpha. These molecules that are released then cause an increased inflammatory response, tissue damage, ulceration, and also fibrosis of the tissue. And this can happen over months or years in an individual with these conditions. Both diseases are relapsing, and here we have an example of what happens in Crohn's disease. So at the bottom we've got time over years. So early on in the disease you've got very little tissue damage, but every time there is an inflammatory response, and this is shown by the dark blue line, what happens is the tissue gets more and more damaged. So it starts off, usually you get issues with the bowel or the oral tissue, which is OFG. You get a severe bout of the thing, and this is usually where you ends up being hospitalised or going to see a GP. In this stage, hopefully you get diagnosed, but what happens is you start to lay down the foundations for worsening conditions and worse outcome with bowel damage. Every time then, from then on, you have a flare or an episode, the damage gets worse, and then you end up having to require surgery. And once you have surgery, then of course this is not curative for inflammatory bowel disease, specifically Crohn's disease, and therefore you get additional inflammation and more damage. So the area of window of opportunity for treating these individuals and diagnosing them is as early as possible. If you can diagnose them early, It means that you can treat them quicker and you can hopefully slow down the progression of this disease. So the aim of the research that we've been carrying out is to understand the process of driving the disease, or what drives this disease, what causes this disease, try and identify biomarkers or things that we can look at for diagnosis and prognosis, and discovering how to improve the management of this disease over long periods, so to slow down the damage of the tissue and hopefully reduce the amount of surgeries they have to undergo and also stop the fibrosis of the tissue. So I'm going to talk about a number of studies that have been carried out in the Dentistry Institute and also in Newcastle University with a colleague of mine called Chris Nile. So I'm going to talk about, first of all, an audit that we carried out. So we looked at all of the patients that are currently attending the Eastern Dental Hospital and UCLH. And we looked at those in the case of OFGs and started to stratify them. We also conducted genetic sequencing of OFG patients. And we tested the immune system within these patients to see how their immune system works in the tissue culture system in the lab. And we've also looked at environmental factors that we'll discuss. And the ongoing study we're doing at the moment is looking at the oral inflammatory immune response of the patients with inflammatory oral facial granulomatosis, and this is in collaboration with Newcastle University. And then finally, I'll quickly mention the two clinical studies that we're hoping to get up and running. There's one clinical trial looking at the acceptability of steroid injections as an early treatment called SWELL. And there's also the program that we're talking about now with our collaborators in Arena, looking at trying to develop a blood-based diagnostic for OFG to speed up diagnostics and prognostic capabilities of the clinic. So we identified 93 OFG patients within the Eastern Dental Hospital, and of these, the age of onset was about 23 years of age. So it was relatively young. I don't think this is a lifelong disease, so it's once they've had it, they haven't come alive. But the range was quite dramatic. It started off, the earliest person we identified was about 8 years of age, and the oldest was about 74 years of age. So this can occur at any age of any stage of life, only those around about your 20s. When we looked at these in more detail, just over half of them also had IBD. So about 47% of them had OFG alone at the stage we have them in the clinic, but about 53% of them have IBD. And of those 53, what we found was that the people with OFG and Crohn's disease had a significantly earlier onset of the disease, so their onset of disease was just below the age of 20, compared to OFG patients alone, where their age of onset was in their 30s. And interestingly, IBD, usually the age of onset was around about 30 as well. So you can see if you suffer from IBD and OFG together, the age of onset is earlier, and this usually ends up with a more problematic condition over your lifetime. Well, the people that we found that had OFG, 44% of them were diagnosed with OFG before Crohn's disease was diagnosed, and then 56 of them had the OFG diagnosed after Crohn's disease. And you can see the number of individuals, it was up to 6 years before Crohn's disease developed in those people. So Crohn's disease and OFG doesn't always have to start at the same time. Sometimes it can be years between the two conditions. From the genetic studies, we found that most of the population that we were looking at within the Eastern Dental Institute were from the European origin. So the black dots cluster around the British European red dots in this plot, and the number of individuals also came from the African community. But we have a relatively homogeneous kind of mixed genetically in these patients. When we sequenced these patients, we found very little way in evidence of a specific genetic cause for this disease, but that was mainly due to low numbers, more than the fact that there wasn't a genetic influence. So our current study where we're looking at the OFG patients is in Newcastle University and also part listed in Glasgow University. Saliva was collected from 40 healthy controls and 32 Crohn's patients. The saliva that was collected was then used to look for immune markers to see what type of immune response was going on in the oral cavity in patients with OFG, and also to look at the bacterial composition to try and determine if bacteria have some role to play in OFG. What we found was that the inflammatory markers were all elevated, not surprisingly because it's an inflammatory disease, but they had a hallmark of a pro-inflammatory response. And we saw large numbers of pro-inflammatory molecules that drive inflammation, such as IL-6, CXCL9 and CCL2. And then here you can see the individual pattern of IL-6 on the bottom right-hand corner. And this is showing, verifying the assay on the other side, showing that IL-6 is significantly elevated in OFG patients compared to healthy controls. So they definitely have an inflammatory response going on in their saliva. But interestingly, when we looked at the microbiome, we're unable to see any difference in the microbiome in people with OFG compared to healthy controls. This was both in diversity, in numbers, and in composition. So it looks like in OFG, certainly the cohort that we're looking at, there is not a specific change in the microbiome in those individuals. But what we were able to show was that the individuals with OFG do have an abnormal response to bacteria. So we took, again, we're just trying to peripheral blood from OFG patients and healthy control. We isolated the white blood cells that were a new component of the white blood cell. We cultured the macrophages, and then we cultured macrophages with bacteria. And the bacteria that we cultured with here was just straightforward lab-based E. coli. And what we could see was if we mixed the bacteria with the immune cells and macrophages, they produced an increased secretion of pro-inflammatory cytokines, very similar to what we were seeing with the saliva. This was true not only for E. coli, but we tried a number of other bacterial strains, and all of the results were the same. Bacterial exposure to cells from OFG patients produced higher levels of cytokines. This could be the reason for why inflammation is elevated in these individuals. It's not the type of bacteria, it's just the bacterial response in these individuals is abnormal. So we've shown that individuals with both OFG and Crohn's disease tend to be diagnosed younger than those with OFG or IBD alone. OFG may cause an overactive immune response to bacteria in the oral cavity, but it is not dependent on the type of bacteria. It is just bacteria as a whole seems to be driving. But the other thing is that we haven't looked at here so far is environmental factors. So does environmental factors play a role, and what should we look at? So we know from previous studies that cinnamon and something called sodium benzoate are associated with OFG. It's been shown in the past that if you take cinnamon and benzoate away from your diet, it has a 40% of patients respond in a positive way and show symptom improvements. It didn't seem to be affected by Crohn's disease, so this was anybody with OFG, irrespective of having Crohn's disease. And the benzoates that they had to take. The problem with benzoates, though, is that it's in everything. It's not just in food. It's also in pharmaceuticals, it's in personalised care products, it's in beauty products, it's in toothpaste, it's in mouthwash. Sodium benzoate is found almost everywhere you look, and therefore it's extremely difficult to remove it from your diet. But one of the questions is, what does sodium benzoate do, and why is it involved in this disease setting? So one of the studies we did, we took macrophages that we know are abnormal from OFG patients. So we took macrophages from healthy controls and we soaked them in sodium benzoate. Sodium benzoate influences the cell phenotype, it changes the cell. So then when they're exposed to bacteria, what happens is you get an elevated pro-inflammatory response. So it looks like sodium benzoate, once it's exposed to the immune system, is able to increase the inflammatory response of these cells. This could be one of the reasons why sodium benzoate in your diet in the oral cavity drives a disease that is driven by overactive immune responses. So it could be that it just exacerbates the condition that is underlying, or it makes the flares more frequent in these individuals. So therefore, removing it from the diet or taking it out of the oral cavity may be one of the reasons why they see a benefit in these individuals. So eliminating sodium benzoate from the diet seems like it's a good idea, but like I say, it only seems to work in about 40–50% of patients. So it's something that we need to look at in more detail. It doesn't seem to be in response to inflammatory bowel disease. So OFG patients with or without inflammatory bowel disease respond equally to sodium benzoate-free diet. So it's currently a thing that we need to look at of why do certain people respond and other people do not to this sodium benzoate-free diet. So the future directions is we'd like to be able to have early identification of individuals with OFG, so diagnose OFG very quickly. It's quite a while to know, it's quite complex, and you'll hear about this later. But also I'd like to be able to work out quite early on if these people are going to go on to develop Crohn's disease, and hopefully pick them up earlier and get them treated earlier for their conditions before it gets to a more chronic condition. We'd like to determine who's likely to go on to develop it. Dietary impacts. Who will benefit from sodium benzoate? Is it possible to detect early on who can do it? Because benzoate-free diets are very difficult to be maintained and not overly well taken up by patients. So if we can find people who will or will not respond to sodium-free benzoate diets, that would be a good idea. And ultimately, we would like to have a very simple, fast diagnostic prognostic test available for all the patients who come into the clinic. So finally, I just want to show you the SWELL project that's going on. So I just want to highlight this. This is one of the first clinical-based trials studies that have been run for years in OFG. This is run by Professor Stefano Fedeli from the Eastern Dental Hospital and Valeria Misneros. And this is where they're going to do patient recruitment and treat them with oral steroids, injections weekly. And this is hopefully to treat the fibrosis and the inflammation in the oral tissue. So if you're interested in this study or you want any more information, you can contact the email address that is available at the bottom of this. So finally, I'd just like to thank the people who are involved in this. So the Eastern Dental Hospital have provided most of the help for this. So this is Professor Stephen Porter and Stefano Fedeli. And most of the work was carried out by Helen Peterson, Andrea Rivera and Cooper Patel. And all of the work in collaboration with Newcastle and Glasgow University was under the management of Dr. Chris Nile. So thank you very much for listening. And now we'll go on to about the clinical aspects of it.
There are some questions online as well.
Okay, so if you have any questions, I'll be happy to answer them now.
I think there's a question. There's a question in the chat.
Yes, I'm very surprised it was no different. I'm slightly disappointed because it was a large study. It's maybe that we were sampling from the wrong site. Maybe the saliva is not the best site. Maybe if we went into the soft tissue and looked at the microbes that were associated directly with the soft tissue, we might see some difference. But it was, we were hoping to find some change in the microbiome composition between people with disease and people without. Yeah, it was a good check.
Ask the question. Oh, waiting. When the monoclonal macrophages you treated with sodium benzoate to augment those responses, were they patient derived or were they healthy?
Healthy controls. At the time, we didn't have access to the patient blood, so we don't know if it makes the patients even worse.
Yeah.
Or it just makes healthy controls like the OFG patient.
Yeah, so even in healthy derived.
Yeah, drove it again. So it messed around with the superoxide inside the cell.
Interesting. Well, you said in benzoate therapies.
For urea disease,
Urea for hyperammonemia.
yeah. But it's also it's a reactive oxygen species is related to suppressive. Okay. I don't know what it is.
Let me just stop sharing. I'm going to. Share again.
This one is.
Yes. Hello everyone. I hope you can all see this on the screen. My name is Tati. I'm one of the oral medicine lecturers and special registrars at UCL. I'm working at UCLH in the trust as well, seeing patients in the oral medicine clinics. And it's my pleasure just to be here to give you a bit of an overview of the clinical aspects of the conditions. I think Andrew gave you a good introduction, broad information about systemic inflammatory diseases causing problems in the oral cavity. And just for the benefit of a mixed audience that we might have today, I think, as a background, I'm a dentist, and I'm going to be oral medicine specialist. And as oral medicine practitioners, we tend to not look much at the teeth, as usual dentists, but we tend to look at the soft parts of the mouth. And just to give you a broader context, if you're not aware of what we do in our specialty, but if you think about all the other structures in your mouth, not your teeth, so if you think about your tongue, the inside of your cheeks, your lips, the roof of your mouth, all parts of your mouth that can be affected by other diseases, and this is what we're interested on. And if you think in the smaller context, in this picture, for example, you can see that the lining of the mouth, so your oral mucosa, is composed of many other of the structures or the types of cells, and they're all connected to your general body, and hence why you expect to see all this interaction with the systemic conditions as well. And as Prof. Smith suggested about the multifactor, different factors contributing to the development of inflammatory disease and other systemic diseases, you have different components in terms of genetics, environment, lifestyle, your immune system, if you're susceptible or not to develop diseases, they all contribute to the overall picture. So these all count, and that's why the soft tissues in your mouth can be the first to show some underlying disease, and it's helpful for us to start investigating early on. So it's very important for us to be tuned in that oral manifestations are present in the beginning of systemic conditions. And some of the possible signs, if you're not aware, if you're not a healthcare professional, but it's some possible signs that can have different sorts of presentations in the mouth that can suggest some systemic involvement. That could be a sign of systemic involvement that we should investigate further. And so you can have, in the pictures you can see here, so we work a bit like in a detective role, that we try to see what we see in the mouth and what we could correlate with systemic diseases. And you can have things ranging from white patches to infectious disease, for example, as a general common thrush that sometimes can be related to underlying disease. Or sometimes you can see lumps that can be related to viral malignancy or developmental diseases. You can have conditions of dry mouth. They can have problems with your salivary glands as part of the structures in the mouth that provides the lubrication of the mouth, and that has a severe impact on quality of life and dental complications. You can also have ulcerations in your mouth, so raw cuts that I tend to describe to patients, that you have this raw cut, usually quite painful, and they can come and go, they can be progressive, and they can also refer to systemic conditions. And sometimes you can have swelling, which is the focus of our talk today, in terms of it could involve any part of the oral cavity and of the neck as well, and it can also represent important underlying systemic disease. So that all made sense. This is just an overview that you can have some examples of lots of different underlying conditions, and it can involve pretty much all the systems in our bodies, and it just would manifest in our mouth in a different way. So no different ways that I gave you some examples now. And the ways that we can detect them, there are several tests that you can detect them, including blood tests, skin tests, particularly patch testing for allergens. I'm going to talk about this later. Swabs for infection, scans, x-rays, or a biopsy can be quite helpful in some instances to confirm what's inside the tissue. And some special tests for particular diseases, that, for example, fecal tests and immunofluorescence that can be helpful, particularly in IBD as well. And just with a focus on OFG, and if people have any questions, please put in the chat. We'll endeavour to look at all of them at the end and try to talk to all of you online as well, and you guys here as well. but just focusing more on the OFG and IBD and Crohn's and ulcerative colitis in this workshop. But I'm just going to give a brief on the OFG in terms of the clinical presentations, what it is, and what we can do about these conditions at this moment in time. But hopefully we'll get better in the future. But orofacial granulomatosis is idiopathic. We don't really know the actual cause of this condition. It's chronic, it's long-standing, it's persisting. It's not something we can cure and remove all the causes. So we just need to manage the condition along the way. And it's caused by inflammation mainly on the lips. So about more than 90% of patients would have the inflammation on the lips, but it can also affect, you can also have face swelling or intraoral swelling or other symptoms intraorally as well. And I'm going to show you some in a minute. And it's important to note that orofacial granulomatosis at this moment in time is considered an exclusion diagnosis. So we're not talking about, we are trying to exclude all possible conditions, and if we don't find anything, we consider that the patient can have OFG. And the main conditions that we need to exclude that can have similar either presentations or a similar disease mechanism with the granulomas that Professor Mintz just explained, that is the hallmark of the disease, is angioedema, sarcoidosis, Crohn's disease, types of cheilitis, tuberculosis, infectious disease like tuberculosis, leprosy, foreign body reactions, and Usher syndrome. But these are it's more on the differential side, so just to ensure that patients don't have these conditions in the lung. And potential triggers for OFG, they're reported as hypersensitivity, but by a specific type, the delayed type 4 mechanism of hypersensitivity. It has linked to IgE levels, although it's not sensitive enough to be one of the tests to diagnose OFG, but it is considered, it's one of the signs that it's being reported that it can be raised for OFG patients, but not always. And in keeping with that, there's a common association. So over 80% of patients can have an association with some type of atopy, so asthma, eczema, hay fever, or any type of allergy syndrome. There's not a really known prevalence reported so far, and this may be because this is an exclusion diagnosis, so on literature it's quite difficult to see how prevalent this is, although we know that it can be quite uncommon. It's as we saw just now as well, it's more common in young adults. There was a median age reported of 23 years old. There's no predilection for gender or for race or for geographic regions. And there's a wide range of treatments, and that will really depend on what patients are presenting. So it depends on severity. And as we don't know yet how we can stratify these patients and really predict who's going to develop more symptoms or not, we really need to be treating them based on what we have clinically and with their progress. So it's really important in that sense that we have a multidisciplinary approach. So most of the time we at least ensure that there's no underlying disease. And if we need multidisciplinary support, we should include at least gastroenterologists, dietitians, psychology, and sometimes the surgeons that we're going to see as well. So I just brought you some photographs from some reports in literature that you can see the clinical manifestation. And as I said, lip swelling is about more than 90% of the cases. And as you can see, you can have either one of the lips with the presentation, you can have both upper and lower lips, and it varies in degrees a lot. So you see a big range of patients having very mild disease, sometimes almost imperceptible, not very perceptible, and then, or sometimes family members would say, I noticed this difference, but not necessarily the patient. And other times, like this one, you can see it's more obvious and more noticeable than other cases. And as a secondary effect, you can also have a common association with infection. And you can see these crackings and redness on corners of the mouth is what we call angular cheilitis. And it's caused by the fungal infection that is present in our mouth, but you can't overgrow in these cases. And sometimes it happens because of the actual cracking of the lips, because they swell so much. You can have the exposure, and you can have bacterial and fungal infections superimposing on the cracks, or you can have the angular cheilitis presentation like this one. Other manifestations that we see are perioral erythema, so around the lips and on the face as well. You can have this redness and swelling as well. Inside your mouth, you can see some what we call cobblestoning, so this foldings of this swelling of the inside of the lining of the mouth. And sometimes you can see that in the as a common presentation as well, gingival swelling. That can be more inflamed or not. This picture is not so red or inflamed, but you can have varied presentations as well. Less common presentations, but you can also see in OFG, is oral linear ulcers. So you can see here, you can see the junction between the gum and the inside of the cheek, and in between, you can have some line ulcerations, so line raw cuts, or some swellings. So you can see these tags, this kind of overgrowth of the lining of the mouth. Sometimes you can see what we call mucosal tags. They're not necessarily symptomatic, they don't necessarily bother patients, but you can see this overgrowth of the lining of the mouth in different areas as well, so inside your cheeks, and sometimes under your tongue, like in this picture, it's known as Fallon sign. And this tends to not be so problematic, but it tends to be more associated with patients presenting with Crohn's disease later on. So there is a clinical impression that you have a more anterior presentation of this condition, these symptoms. It tends to be more in keeping with OFG compared to a more posterior manifestation with intraoral lesions, more than the lip swelling that would be more in keeping with, more likely with Crohn's disease, more towards Crohn's disease. And so now I just want to move a bit to Crohn's disease and show a little bit of the difference on, with OFG, and then we can discuss a little bit whether we think this is the same condition or not. And if we move to Crohn's disease, again, it's a long-standing chronic inflammatory condition. It can affect, it affects the gastrointestinal tract, as we had a presentation before, and it can have progressive bowel damage and disability. As Prof. Smith well said about being multifactorial, so you have lots of different factors contributing to the cause of this disease, and you can just regulate the lining of the gastrointestinal tract, and in susceptible individuals who will develop the disease. It's rare, but it's increasing in certain countries, particularly with early onset in pediatric children, and the prevalence tends to be, it's reported about 3 in 100,000 people, so it's not very common, but it's varying according to new reports. And it's usually diagnosed between 18 to 35 years old, and there seems to be a second peak later on, 50 to 60 years old. There are some reports about lower risk of women developing Crohn's disease during childhood compared to colitis, but that's again geographically dependent, and there's varied reports in this regard. And again, similar to OFG, there's a wide range of treatments and according to severity, and it really depends, and it really relies on a multidisciplinary approach depending on which areas are involved and how severe they are. And so 60% of people with Crohn's disease can have oral symptoms, and they tend to have, again, as I said, a more posterior pattern compared to OFG. And lots of these patients, about 50% of these patients, can have extraintestinal symptoms, and including the skin, including the joints, present fatigue, ocular symptoms, and the oral symptoms as well. And some of the oral signs, as I mentioned with the photos before, you can have some of the gingival, the gum enlargement, you can have the lip and the inside of the mouth swelling, the cobblestoning, linear ulceration, so the linear rock cuts, and the mucosal tags, so the little lumps inside the mouth. And in the gastrointestinal symptoms, most of the time what we ask initially is really to investigate if there's any chronic diarrhea, abdominal pain, unexpected weight loss, any change in bowel habits at all. And if for children population, we ask about growth or puberty delay. And that's really red flags for us to really commence the investigations. We tend to commence the investigations regardless, because you can have a proportion of patients without any gastrointestinal symptom. There is what we call subclinical symptoms, and even though we still look for the basic investigations to see if there's any indication of systemic inflammation or not. And patients can also have some unspecific symptoms. As I mentioned, with angular cheilitis, as the infection of the corners of the mouth, that can happen as a result. You can have some rashes around the lips. You can have the fissuring because of the amount of swelling. You can have some cracks and fissuring of the lips. And sometimes you can have dysesthesia, which is an abnormal sensation of the mouth caused by this persistent recurrent inflammation. Some more sensitivity, some more pain inside the mouth, and also some mouth ulcers that can look like benign, with no particular cause of mouth ulcers that a lot of people present. However, this is more a secondary symptom of being malabsorption, so you can have underlying anemia or deficiencies that can lead to these mouth ulcers rather than the condition itself. So it's a big range of presentations. And if you compare to ulcerative colitis, it's not as associated to oral involvement as Crohn's disease. So again, just a very quick recap, but it's another part of the IBD conditions, chronic inflammatory condition, predominantly on the large intestine, unknown cause, but is also known to be, also suggested to be multifactorial, similar to Crohn's. The same risk factors as chronic disease that we discussed. The peak onset seemed to be similar at 30 to 40 years old to OFG, and the main symptoms would be similar to Crohn's. So I think the main point is we don't focus so much on ulcerative colitis because most of the time the manifestations in the mouth are either secondary to the gastrointestinal disease, with the mouth ulcers, or with a very rare condition that's called piostomatitis verticans. That is a very specific and very rare condition that we need to treat, and we know that it will be underlying ulcerative colitis. And so, as I said, there's some differences in Crohn's and OFG, and with the more anterior walks through the clinical presentation. 20 to 50% of OFG patients would have Crohn's disease at the same time, but again, there's various symptoms. Up to 60% of patients can have diagnosed with Crohn's, but no gastrointestinal symptom at all, so they might not report anything to us when we start investigating. And we still include a lot of our investigations for most of our patients, particularly for children. And most areas of the oral cavity can be affected by OFG and by Crohn's disease. And again, if you have it's more suggested to be related to Crohn's if you have the linear ulcerations, so the linear raw cuts, if you have some blood markers for systemic inflammation, and some abnormalities in the blood tests and the general. And so the discussions are if there's debate if it's the same condition, if it's a spectrum, if it's OFG, will just a mild presentation of Crohn's. There are some evidence now, some genetic testing, some microbiomarkers supporting that they're separate entities. And as we see that not all patients with OFG would develop Crohn's as well, so there's a high suggestion that they are different conditions. And so there's about 20% chance of OFG transforming to true Crohn's disease within the 10 years of the first, most of the time within the first 10 years of the symptoms. And this is particularly important for pediatric patients, for children, where your oral manifestations, your oral signs can be the early signs of disease, and they have a double chance, 20% chance compared to 10% of the adult cohort. So if you see in this graph that children can have a higher chance of developing Crohn's from OFG symptoms within the first 10 years compared to an adult group. And the investigations, it's within those investigations I mentioned previously, most of them we would think about performing when we see patients with OFG symptoms. And as I said, it is an exclusion diagnosis, so we do try to exclude all the mimical conditions or the similar conditions. And so that for that we include blood tests, we try to see if there's any underlying deficiencies, if there's any issues with liver, kidneys, if there's any deficiencies or inflammatory markers, raised inflammatory markers. They're not specific for the condition, but they can give us an idea whether there's a systemic inflammation. And also some specific ones, for example, for sarcoidosis and tuberculosis, for instance, that we need to differentiate. You can think about patch testing. As I said, there's limited use because it's not very sensitive, so it doesn't add much on the treatment, on management options. You can do some swabs for secondary infections. So if you're not sure which treatments to provide, you can do the swabs for that to differentiate between fungal and bacterial infections. You can do scans and X-rays, particularly if there's gastrointestinal or respiratory system symptoms. And you can do a neurobiopsy, but there's a very limited usefulness of the biopsy at this moment because it's not 100% diagnostic, especially with late onset, with late symptoms. You don't seem to have the granulomas that Professor Smith explained. The hallmark is not as present later on, and you can easily miss in the biopsy because the biopsy is a few millimeters size of a sample. So if you think that you just collect a small sample of your lip, you might not necessarily catch the hallmark, so you might be missing the diagnosis, so you can't 100% rely on the biopsy. And that's why it's taken with caution. We only consider the biopsy if we really are not sure or if there's a lot of symptoms presenting. And so it's still challenging, but it's promising because there's some new biological treatments, there are new techniques to discover the differences between the diseases, if there's any way to stratify them, to do early diagnosis and to do early treatments. And it's really important to think about the high psychological impact. And so the effort to find prognostic factors and to identify the early disease and identify early treatments is very important, especially in children. This can affect children a lot, especially with the new cosmetic treatments, that children can have a lot of difficulty at school with this condition. And again, and also there's a wide effectiveness between OFG alone and if you have Crohn's combined. So a lot of the conditions with Crohn's can be more resistant to treatment, and that's something to think about as well in doing early treatment. And this one already said about the pediatric early onset during childhood, that there's high chance of developing Crohn's. And so there's no single treatment that would fit at all. So the last thing I want to talk is just about the treatments available. I think from the survey we did, there's a lot of people interested in this. But there's no single treatment that would fit everyone. We talk a lot about chronic disease in our clinics, and it's a lot about we don't have a cure, we don't have a single fix for the issues, but it's more about accepting and learning how to manage on an individual level rather than curing the condition. And this is really important to communicate to the patients. And it's really highly dependent on how severe and how it's impacting the patient's life. And basically, from patient education, we discuss about the dietary modifications in terms of the cinnamon benzoate diet that we were talking about, and the hypersensitivity trigger that is possible in OFG, that is suggested in OFG, psychological support, medications and surgery in the last instance. And so the treatments are sort of divided. We have initial strategies, so if patients have mild symptoms, we always start with the less invasive and the basic treatments with what we call topical medication. Then we include mouthwashes, ointment sprays, and it's relatively safe, so patients can use this on and off or regularly if they need to, if the recurrence is too often. And they can be based on corticosteroids or non-steroid basis. And you can find different forms of it, so mouthwashes, ointments, and you can and just be aware that some of these medications, for instance, prednisolone, beclomethasone preparations, they can also contain benzoate, so we also just need to be a bit cautious. If it's for OFG, to be a bit more cautious on that. But all of the options are possible to try, and usually we try one at a time on an escalation pattern, so we know which one's working best for each patient, and we do on a dose strength escalation as well. We can think about antimicrobials. So as we mentioned about possible infections superimposing on the oral infestation, so we think about these options as well, and also analgesics or pain relief preparations to just support patients to have a better quality of life. And the next thing that we discuss is also about intralesional corticosteroids that was discussed before, in terms of it seems to be a good treatment with good disease control and reducing the recurrence, reducing how often it comes back. There are two of the larger studies that have been reported. It can show that 60 to 100% disease free between 1 and 4 weeks after the first course. You can have up to 6 months remission. And another study, they also show complete resolution in nearly 60% of patients at 3 months period. It's worth mentioning that it is a good treatment, but it has risks as any other treatment. And if you keep repeating the treatments too often, you have the risk of hyperthermia of the lining of the oral mucosa, some scarring and fibrosis if you keep repeating them. And also about the cinnamon and benzoate-free diet, there is good evidence, good studies showing between 50 to 78% improvement of OFG symptoms after 8 weeks of treatment. And if patients tend to respond to the treatment, we then suggest them to do start including either food or products slowly, one at a time, and to see which ones would be the most triggering ones. So it's not necessarily a diet for a lifetime, but it's about excluding first in the first 3 months, and then after that you have support to reintroduce things slowly. About more than 20% require no other therapies. That has been reported if patients are responsive to this. And obviously there's some issues with the dairies. Sometimes, as Smith mentioned, about how difficult it is for patients, because it's not just foods, it's about oral hygiene products, it's about cosmetics, about medications. Patients can be exposed to the benzoates particularly, and it's quite difficult to deal. And the patch testing, as I said, is not very predictive for effectiveness that we know this time. And just for the more severe and the recurrent involvement of the oral symptoms, we can rely on the systemic antimicrobials. And you have a few options that have been reported, as you can see here in the slide. You can use, some patients report to use them regularly, and they tend to have a more controlled disease. So either mild flares or they have less recurrence than without the antimicrobials. You can also have systemic immune suppression that is more reported in literature, using azathioprine, which is one of the main ones. But there are other options reported so far for more resistant conditions. Systemic steroids with prednisolone, you can have short-term courses, which could be usually our SOS pack. The patients, when they're in really severe flare, you can consider them not too often, because there's serious side effects if we have a continuous treatment. But if patients have recurrence, not more than 3 times a year, this can be an option as well. And again, not everyone would respond to this treatment, so that's why we need to have all these options in our pockets to really see and give accordingly. And the new treatments that are coming up, they're called biologics, and they can cause some sort of immune suppression as well. And the ones that are reported at the moment, they're called the anti-TNF markers, the anti-IL-23, and the anti-integrin receptor antagonist. And there's some of these already reported to be helpful for these conditions. And the last one would be the surgical intervention, that, as you can imagine, is leave for the last option, because it can give you a lot of scarring. It's really reserved for when it's really disfiguring, really resistant conditions. And so, can we predict its progress? So far, we have some evidence out there. I just listed some here that have been shown some signs that, for example, the HLA family, that one of them can be show maybe lower risk of developing Crohn's disease in terms of predicting if it's going to develop or not. The other marker, the A11, can be maybe a negative risk, Crohn's. There's a lot of studies on the NOD2 genetic marker that they don't seem to have in OFG alone, so that could be one avenue that people are investigating now. Some markers in the inflammatory infiltrate itself that they tend to have more of some markers than others in OFG and Crohn's combined, but not so much in OFG alone. And others like Th2 and Th17 subsets, and also fibrotic markers as well that seem to be more in keeping with Crohn's disease as well, with the more complicated cases. So thank you for listening. I hope it wasn't too quick, but I'm happy to take any questions. Let's stop sharing. We'll just check the chat if there's any questions, but thanks, Greg. That's nice to hear from you.
Good evening, everyone. Everything is here. We will talk about new developing approaches. So there's obviously the highlights of what's happening in OFG and IBD, and those are chronic inflammatory conditions. And what we're doing at Avena, we are really moving the field of precision medicine and want to understand how these precision medicine solutions can help of managing the conditions. And one of the work which we are doing with Andrew and Dr. Daddy is developing this precision medicine diagnostics for enabling patients to detect the disease at early stage, but then also can be potentially helpful in managing conditions. So we'll talk about how what technologies right now we have for looking at the underlying reason for many of these chronic conditions. And we will also talk about the technologies which we've been working on for last 7 years with our sister company, which is specialized in glycomics. And we will answer, we'll be happy to answer any questions and potential collaborations at the end. So we've been talking about 2 chronic inflammatory diseases, and in this slide you can also see there are many other chronic inflammatory conditions. And a lot of time we look at these conditions, but we really forget about what is the underlying cause for this disease. And underlying cause, one of the main underlying cause is chronic inflammation. And when we look at how right now healthcare is managing or approaching this chronic inflammatory conditions, we can see that it's typically focusing on managing symptoms rather than looking once they already become apparent. So it's a little bit late. So when Andrew was showing this small window of opportunities which we have to detect the disease and managing it, so it's very, very important to detect, but usually in traditional healthcare approach, we're missing this. And so it also leads to the delayed diagnosis and worse outcomes for a patient. And I think also what is very important what's happening in traditional medicine, patient is really doesn't have any tools in taking part in their disease. So one of the approaches which we'll be discussing is also how can we enable the patients to understand their disease and giving them potentially those tools in looking and tracking this condition as well. So where we really would like to move is towards this precision medicine approach of managing these chronic conditions. So you can see that the precision medicine is moving from the guesswork to more informative precision. What it means in practice is that when the doctor is diagnosing the patient, so very often they don't really have the tools which will give them understanding how the disease course of the patient will go. So the technologies which right now we're developing will enable the practitioners to understand potentially this patient will be having a high inflammatory cause of the disease and potentially also personalized treatments, which right now is not really in the medical practice. So this will enable also personalization of the treatments, and of course, the management of chronic conditions is very expensive. So this hopefully will also lead from to reduce the expense of the treatments. And what are the other things we want to really highlight here? It's a fragmentation. So we really believe that the solutions for this chronic inflammatory disease is not developed yet. So Dr. Tariq is completely right. We have to tell patients that they need to kind of live with that. But then also in this, on the background, there is an opportunity for the researchers and patients and also clinicians working together in order to start creating the solutions. And the fragmentation of the healthcare system, I think it's one of the reasons why we still don't have solutions for many of these chronic inflammatory conditions. So looking at the different approaches to healthcare, so we've been mentioning this precision medicine. So what is it, how it's really different? So we're looking in this identification of the root causes of the disease. So really, how can we look at
logged in?
different biomarkers and look at what was causing this disease and trying to address that cause? Right?
Okay.
Then also we need to consider the multiple layers. So this is very interesting because that comes to, we all have this proteomics and genomics and different omics of.
How are you?
Oh,
Say Ramadan Kareem to everyone.
no. Thank you for watching. Can we have?
We can go quickly. I can
Thank you. So those are the slides which have been discussed. So if somebody can give us a thumbs up, we can see it now. So we're on this slide at the moment.
Yeah.
Okay. So yes, so when we were talking about the considering multiple layers, we need to understand that we can look at the biomarkers, we can look at the different layers of the biomarkers. So there can be symptomatic biomarkers, but there can be also the genetic biomarkers which predispose to a particular condition. And then we also need to talk about or look at the epigenetic factors or environmental factors and somehow analyze it all in order to understand where the patient is. So what we want also to empower patients to track this contributing factor to those diseases. And later on, CJ will talk about the biomarkers which we're developing at Avena. Here at Avena, we're focusing on chronic inflammatory conditions. You're right, in fact, one of our most advanced research been done in inflammatory bowel disease. However, we're also looking at cardiovascular diseases, and we also would be we're very much looking forward in having the project also understand OFG more.
Yeah, now talking about empowering patients and how they can start being part of this conversation of understanding and managing their own chronic inflammatory diseases. So I'm putting here some examples about how they can proactively start tracking and managing their disease. We have two different kind of markers or ways to see this. So we have subjective symptoms, which, as the name implies, there are symptoms, and there are out there several apps to empower patients so they can utilize even a journal to actually track their symptoms. If they're having some issues in their mouth, they can start putting down and writing down, I have this issue because I eat this type of things. So they can have tracking of their symptoms. It can be pain, it can be also the diet, it can be even stress. So the different factors, how they can start tracking. Their apps available digitally, but there are also analogy measurements. That's for the symptoms, which is more qualitative. Now for the quantitative, we obviously have some objective markers, which effectively will measure what happened, what is going on with your body. So there are different tools available, like clinical tests, stool test, urine, blood test, which I'm gonna go deep into the blood test. But we also have some wearables and a lot of digital tools available where we can start tracking how many hours are we sleeping. All those different factors that will eventually have an impact in our overall health. Like for instance, inflammation markers, blood tests, CRP, glycomics, of course, and activity
sleep, I think it's important. HRV, it's also a really good marker for IBD patients if they are presenting or if they are developing also a flare, so something to also consider. Right now I'm just going to focus on the blood test as a clinical marker. So the current traditional medicine, currently available blood markers are usually for inflammation are CRP, IL-6, those different clinical tools available. But the truth is that they cannot differentiate between chronic and acute inflammation. It's just a marker of inflammation. What we're trying to do and where we're trying to push further to actually do a precision medicine approach is we are developing a technology that will be reliable, differentiate between chronic inflammation and acute inflammation. That way we can just focus on understanding, tracking, and then managing the chronic inflammation alone without interference from the acute inflammation.
So glycomics, quick introduction to that. So some of the researchers and clinicians might have heard of that already. So glycomics is part of the omics. We've all heard about the genomics, transcriptomics, and proteomics. So glycomics is the post-translational modifications of the proteins, so which becomes very interesting. So it sits somewhere between, because genetics gives you a predisposition for particular disease, and then you can also already have the disease expressions. So when you start measuring it in the blood, the high HCRP, and Dr. Patty was also mentioning some of the specificities of OFG disease. But why we're so excited about this field of glycomics is that it gives you the indication of that something really start going on wrong, but it's still in your biochemical level. So it's really, you don't see the expression of it yet as a symptom. So so that's why it holds quite a significant protection for this early prognostic biomarkers. So how we detect disease at early stage, and then it can be used also for identifying or more stratifying patients with a different disease course. So here is a beautiful picture of glycans. So they are the tiny sugar molecules. So they attach to the proteins. So approximately 50% all the proteins in our body are glycosylated. What it basically means that these proteins glycans get attached to these proteins, and that it might lead to the change of their functional structure. So when the disease starts progressing, so we see this chronic inflammatory process in the body, and they also, lead to the cascades of different changes in the body, and in the way it's also lead to the change of the blood glycomic patterns. So we can see that using our blood assays. And Cindy will be talking more about our technology, which we call GlyHouse. So GlyHouse is a visual diagnostic technology. So we're looking at the blood samples, and we identifying the glycan structures, and we're looking also at glycans in different types of proteins, depending on which disease we are looking at. So what you see here is our development pipeline. As I mentioned, we're looking at the different varieties of disease with array as well, which is a very interesting project because there we're looking at the power of combination biomarkers, which I think really that's where their future will lie in terms of the diagnosis and all of the precision. So we can look at the separation of the genetics and other markers, but really when we start combining the omics, that becomes even more powerful. So yes, indeed.
So as you mentioned, this is glycan development pipeline, where we can where we have non-disease specific and disease specific biomarkers. The most advanced ones in the non-disease specific biomarker, which is not a diagnostic test, is the immunophility assay. It's already commercially available. So what does immunophility test effectively does? It measures your chronic inflammation without the interference of the acute inflammation. So it actually differentiates between the two of them, and you can track your chronic inflammation for a long period of time. It obviously will give you this multidimensional view of the different factors that might affect you as an individual, where you can learn more about what factor is actually triggering you to have high chronic inflammation, because everybody will just be responding to one specific factor a bit more than others. It's very useful for also anti-inflammatory protocols, so you can see if it's actually working or not with a very specific measurement. It's not just about the symptoms or how they are feeling, but you will have a very specific number that you can see if one protocol, anti-inflammatory protocol or a drug is working or not for the whole chronic inflammation. We have developed to a point that it's a home collection kit test, so it's sent directly to the patient. They will take a very small amount of blood and they will return back to our labs where we will perform the glycemic analysis. We've been working in collaboration with different companies to make this test even easier for the logistic point of view, but also for the patient perspective, which is a core element from Avena, that we want to make sure that the patient is very happy, or at least it's not a stressful event to take the sample, but it's something that less invasive as possible and easy to understand, so they can follow the instructions very well, so we can do the analysis properly. Now, here is a case study of a patient who started utilizing the immunofragility index, and these are the dots of the number I was mentioning, so very specific numbers you can track for long period of times and start identifying why and when is your high chronic inflammation happens. In this case, he started tracking the big seven, that's how we call it, so food, movement, sleep, relationship, biorhythm, stress. And effectively, these two big dots, it's where he was with the highest chronic inflammation, and it was exactly where he was writing some grants and high stress and poor sleep. So he realized that the sleep was his main issue, even though he was eating the same. Here, the sleep factor was very, very important for him. So if he starts just focusing on the sleep, then he will just start reducing the chronic inflammation as an overall.
But it can be different for each individual patient. Would be different. For some people, would be also different depending on how, if they're reducing their weight or if they're having a better diet. So that's again giving you a very precise understanding of your own body, which is useful in some particular cases.
Now, for the specific biomarker, which disease-specific biomarker, which Zelina mentioned, it's inflammatory bowel disease. We've been looking into this disease for the last few years, and we've been collaborating with TGU, University of Oxford, and trying to make this biomarker prognostic and predictive biomarker. Right now, it's in a TRL 4/5 study, where we analyze more than 400 samples for newly diagnosed patients, and we compare it with the current biomarkers for chronic inflammation, and you can see that glandular IBD outperform. This effectively is showing the prediction power, and this is specifically for patients' treatment escalation. So with this biomarker, we were able to determine if the patient with high chronic inflammation, they will require treatment escalation 18 months in advance, meaning that the IBD disease was more aggressive.
So I'll just add something. Basically, what we are able to predict, we can see up until 18 months in the future if the patient is going to have a flare. So that's all specific to IBD. And then the clinician would be able to make a decision whether they need to increase the dosage of the drug or potentially change the drug. So that's what the technology has been investigated to use at the moment. So we're also hoping to run more clinical studies and understanding whether this can be also applicable for the diagnosing patients, which can be specifically interesting when looking at their interlinks between IBD and lurching.
Now, just wrapping up about precision medicine, we need to understand that health is a complete network and stop looking at just the systematic or the very specific system isolated. But I'm sure that Andrew was mentioning about the microbiome and the immune system. So if we start putting the pieces of the puzzle all together, we can then understand the overall health or the overall disease, and then how to tackle. So we have the different factors. We already discussed the different tools we have. Maybe future tools will be coming in the future. But then also we have the different analyses. Now, how can we make this data and then these different analyses with a more multi-omic integration? So that's, I think, the next step for the precision medicine to actually be adopted. How can all these data from diverse even studies can be put together so we can integrate this data not just as factors, then as data, and then how can we make sense of this? And for that, we will obviously require a cross-disciplinary integration or more cross-disciplinary approach. So we will be able to actually understand each disease better and then understand the relationship between these different diseases, if there's any. Now, for the conclusions and obviously future directions, we are collaborating right now with UCL, with Professor Andrew and Tati, to try to develop a blood assay that will be a diagnostic for OFG and IBD. Right now, we have this very strong data from the IBD aspect, but then if we can combine it somehow or develop something with OFG, that thing will be very interesting. And again, just reiterating, the future of precision medicine might be also the multi-omic approach, because different companies are doing really good with the understanding with the specific omics, but it won't mean anything if we cannot combine with bioinformatics systems. Again, collaboration is key, and I think hopefully still in the audience we have some dentists, more in the dental side. Really, that would be a key element. So the dentists play a big role in this to identify any type of diseases or a lot of diseases, hidden diseases, very early, because the oral health can mean or can give us very interesting insights from the overall health of an individual. So we need to collaborate.
Yes, so this is our team, and if you have any questions right now, pop it in the chat, and looking forward to speak to you soon at the beginning. So there are some from participants. Any questions to speakers before or to us? So we'll just wait for a few moments if you guys have some questions.
Unrelated questions.
Huh?
Two different questions for you guys.
To the presenters earlier as well, so.
Do we know why traditional medicine cannot identify between chronic disease and
Differentiating, yeah.
between the chronic disease and the acute disease? Do we know that as of today? Why? And the second one is, when are you planning to launch Glide Health IBD, and how much is it going to cost roughly?
I think the first question is, it's more about also using this technologies which enabled you to differentiate, like to develop those biomarkers. It's a cost, but then also integration of this new innovative technology into the medical practice. So it's quite a lengthy process of get all of these approvals, and then also give the understanding to the clinicians. So we can do a lot of research and we can find it very useful, but then the clinicians also need to start using, the patients need to start using. So I would say this is an evolving process, and hopefully, we're moving towards that. And the second one is for the inflammatory bowel disease. We will be hopefully running the prospective studies quite soon. Also, our sister company is involved in quite large grants where they're looking at the investigation and moving it forward. But I would hope, it would be in the next 2 to 3 years. So that's when we will have a specific, commercially viable product. Another thing is the commercialization might not necessarily come to direct to the patient. Commercialization can be really different parts of that. Any other questions?
Have you looked at IBS? And because the problem with most people with IBD is they get kind of told it's IBS for quite a few years before they get an IBD diagnosis. Have you had any ability to see if there's a differential response in your glycomic test for IBS patients compared to IBD patients? And would it be something that would be able to probably diagnose it quicker? Within the GP surgery, where most people get held up for quite a large amount of time before getting referred to GI.
Because I think with IBS, because it's a syndrome, so there's no kind of a specific diagnosis to that. It's more also, the short answer to that is no, we don't have any data or like research data on that. However, it's a very interesting field. Again, if you start linking, where it starts with microbiome and, going all down to the intestine. So I think that can be the project for sure for run, but we haven't looked at the hard data about it. So
it's just that there's no classic inflammatory marker with IBS.
Exactly.
And if they don't get it at the right time in the early blood tests, is it possible that they could see people with chronic inflammation, or if it picks a flare 18 months in advance, maybe you'll be able to pick it up quicker.
It's also about
if people who are going to develop inflammatory bowel disease instead of inflammatory bowel syndrome.
I think it's also about this qualitative and quantitative symptoms, right? Sometimes it's very difficult also when the patients report the pain. And we've been in this very interesting conference organized by Lilly's, and it was a lot of clinicians and patients, and they were giving this example. Sometimes you actually can see that the patient gut is so inflamed, but then they would not feel anything. And then, they usually have no symptoms. And then they will come to the screening test for colonoscopy or for endoscopy. And they will see that their gut is really deteriorating rapidly, and the other cases around. So I think it's it needs to be investigated further, and it needs to be quite a collaboration for people to understand. Because we, for instance, would be sitting here as a researcher who would not have this piece of information. That there can be symptomatic or asymptomatic, and that's the difficulties I think with IBS as well, right? Because people can be symptomatic and have nothing, and the other way around.
Yeah. I just wonder if there was a way to differentiate them early.
Yeah.
Identify the IBD population within the IBS.
No, that's true.
And the
because many of them
diagnosis.
have the symptoms.
Because
Yes. So that would be definitely the pathway. If we would look at the development of the diagnostic test, that's definitely the pathway. Look at the people with a high chronic inflammation, medication, even dentistry, and then also looking at people with IBS and testing them earlier rather than later. If we don't have any questions online, thank you very much.
So that's all right. Yeah, if you haven't got your online,
of course.
So if I understood, then your product that you're looking to commercialise or looking to use is a direct patient finger cold blood sample.
Yes,
is that right?
correct. It's a finger prick test. It can be either direct or it can be used in the clinic as well or by the practitioner. So it's just we want the patients at your desk, where we want to develop the home blood kits.
Great, makes perfect sense. Your cohorts that you validated it, for example, the IBD cohort, presumably they're stored serum and plasma, though, aren't they? So what's the difference in sample type and results or validity? Because they're different samples, aren't they? Do you see what I mean?
Yes. So the thing is that this blood collection test kit we developed quite recently, and all of the IBD specifically studies, they were done on the samples serum, and they were done more kind of retrospective patients and under the grant programs. So we don't really have that yet data to compare, the kind of finger prick with that. Now, once we run the new clinical study, we will be also utilizing this blood collection kit, which will enable us. But yes, that's also the area of the interest, right? Because usually the clinical trials are run in the non-convenient way of patient. So how can we use it?
Yes, it's great to a patient-centric sense, but it's just that validating the data. You're collecting data prospectively, I guess. But the stored data can't have been on that platform. Must have been. I'm guessing it must have been on the server platform. Yeah, okay. But but in terms of the proteins that you're studying, then most of them are not within blood cells, hematological cells. They're circulating proteins, I guess, generally.
Yes.
So that's why you're anticipating that the results would be roughly equivalent.
Yes.
Yeah. Okay, makes sense. So, thank you.
What validation talk as well? Do you validate this with any genomic data as well to see whether this is correlating with the genomic data? Because I can see the advantage of being patient-centered, simple possibly simple technique. But was this validated?
So this idea of genetics actually and combination biomarker didn't come from nothing. So actually we're collaborating with a variety of companies and also researchers. So for instance, for the already we did a small TRL3 study and we're finishing the grant program. So in 1 month we will have more results of that. But what we did there, we exactly combined the glycomics with proteomics and genetic data. So they had highly characterized patient database. So we were able to combine those. So again, results would be reported by end of March. We will see it. Then on the other side, we are talking to this company, the US-based company, and they have larger biobank data than the UK biobank. So they're commercial companies. So they merged several companies. They specifically focus on IBD. That's why we start talking to them, or like one of their focus on IBD. They're not specifically focused. But they're basically, they have their biobank samples, tissues. They also have imaging, exactly. So what we specifically want to do with them is to look how, if we combine the genetic data they have, maybe even biopsy, but biopsy would be difficult because, the tissue sample size, and then also they're based in the US, so it might be more complicated if we want to do that. But yes, the idea is to also run the study with them in combining that for the IBD patient. So that's where we're in discussion with them. We have some sparkling water and I think it's on.
Sorry for the people who's online.
Missing out on that, yes.
But thank you so much for joining, and we will be sharing the recording very soon with the slides as well.
And you all have Cindy contact details, and I guess if there's any question to ask Dr. Tali or Dr. Andrew, please just write to her and we'll make sure that we're coordinated.
Thank you so much.